Hi, my name is Aurangzeb Ahmad. I'm a research scientist at Kensai. In this presentation, I shall be summarizing results related to predicting the patient state of pediatric patients in ICUs. The work is the result of collaboration between Kensai and Children's National Medical Center in Washington, D.C. So the exact problem that we are considering is the problem of characterizing and predicting the condition of pediatric patients in intensive care units, also known as PICUs. The population that we consider is often typified by rapid changes in the condition of the patient. And so because of that, it necessitates predictions that can capture transition in patient states. And so that is what we are focusing on. Currently, most of these assessments of the patient conditions are done using domain-based scoring systems. So these scores are often used for risk stratification to employ preventive measures, which we will discuss in a few slides. So the scenarios that we are describing or considering involve clinical deterioration, which is often described as rapid change in the condition of a patient. A delay in recognizing the change in the condition can lead to worse clinical outcomes, decline in quality of life, and extreme cases, even death. The population that we are considering is the pediatric population, and while it's the case that only 2% of pediatric patients require intensive care services, the ones that do experience significant numbers of morbidity, and thus this is an important problem to consider. And so thus reducing the morbidity or the number of deaths is highly contingent on timely recognition of the changing clinical needs of the patient. So this visual gives an idea of the kind of patients that we are talking about for this use case. So patients in ICUs often require a high level of care as compared to patients in other units for any given hospital. The condition of certain patients can deteriorate quickly, and so because of that, it requires, let's say, sudden attention from the medical staff. That said, it can often be challenging, and that's mainly because risk stratification may be needed for resource allocation for the medical staff, and especially during the time of COVID, this problem has becoming quite prominent. This brings us to risk scoring models, which are used in healthcare. The main idea behind these models is that given a number of factors, it gives a risk score, which can be used as a proxy for the condition of a patient. One of the oldest risk scoring model, which is in fact used still to this day, is a risk score for newborns, also known as the ACPAR scoring system, which was proposed in 1952. Another commonly used scoring model is the COMMA scale, which is used to assess an individual's neurological status by evaluating three subscores: eye, verbal, and motor responses. The Apache score is yet another commonly used model or scoring system, which links the risk of mortality to the number of organs failed. In the context of pediatric mortality, which is most relevant for our use case, the most widely used pediatric mortality risk score is the PRISM score developed by Dr. Murray Pollack. The current version of the PRISM score is the PRISM 3 score, which consists of 17 physiological variables, for example, vital signs, blood gas measures, and lab results from metabolic tests, blood clots, and clotting studies. PRISM is a physiologically based score used to quantify the physiological derangement of a pediatric patient. When combined with other variables, it can be used to compute expected mortality risk. Additionally, the Pediatric Index of Mortality, or the PIM score, is another metric that is often used for mortality prediction for pediatric ICU populations. The dataset that we use is the HealthFacts dataset, which was created by Cerner. The time span considered spans from January 2009 to June 2016, which corresponds to approximately 2 million records and just over 42,000 encounters. The data can be divided into 5 broad categories as follows. We have pharmacy data, lab data, billing data, clinical events data, which consist of vital signs, pain, sedation, COMMA scales, respiratory therapy, etc. and microbiology related information. For example, culture details, organisms isolated, so on and so forth. The union of these various aforementioned sources resulted in a feature set of 1,131 features divided in terms of the various categories as described in this table. So mainly in terms of demographics, temporal data, labs, medications, vitals, etc. While the number of features may seem large, we note that many of these features are in fact indicator variables. For example, in terms of, let's say, gender, if the data is encoded in terms of male, female, and other, uh, when it was encoded, it gets encoded as three different features, hence the larger number of features that we observe in this table. The cohort that was selected consisted of the union of the following two cohorts. The main thing to note is that in terms of age, in years or hours, the data was not missing, and the age was greater than 0, and the range being less than or equal to 21 years. In terms of setting, so in one kit, it had to be an inpatient patient type, or had to be for a particular care setting type, such that the source was in one of the following as described here. The main problem that is addressed is predicting the current and the future states of the patient. This can be defined in terms of whether the patient is in ICU, not ICU, and in some versions of the problem that we addressed, whether the patient is in transition. That can be defined in terms of the n number of next steps, so where n being equal to 1, 2, 3, or 4. The model is described as a binary classification problem where the prediction is done at the entity level of the encounter. So we predict what is the condition of the patient going to be in the next 4 timestamps for that encounter. So when timestamp is 1, then the next 4 hours. Timestamp is 2, then that would mean that 4 to 8 hours, so on and so forth. In the binary classification version, the states that we are predicting are whether the patient is in ICU or not ICU, and we use standard cross-validation and the following set of standard classifiers as described here. Best results were obtained from the random forest model, and thus, in the interest of time and space, we are only showing the results for the random forest in addition to the two baselines. Demi-stratified classifier is a baseline model which predicts at random with respect to the relative distribution of the classes. Logistic regression was also used as a baseline. These plots also reveal that the best model, in this case the random forest model, is sufficiently well calibrated. That said, model calibration can still be improved. The AUS of the model is relatively high, 0.97, and the threshold tuning plots also reveal that the model has sufficiently good predictive power as measured by precision and recall. Lastly, the SLA plot, the sensitive versus low alert rate, reveals that the model does not degrade when the model confidence is low. Here we show the summary of the results for predicting the current and the future state for the next 4 timestamps. The results demonstrate that we do get sufficiently high results from across the board for predicting future states. We also computed the Matthews correlation coefficient for the results, since the metric is regarded as a good way to capture different aspects of the confusion matrix and a signal number. The overall performance gives us thus confidence the model performs sufficiently well. In addition to just predicting two states, that is ICU and non-ICU, we pose another version of the problem, which is predicting the tertiary states, that is ICU, not ICU, and transition states for the model. The results for one of the states, which is the next future state, is given in this table, along with the baselines. The baselines are the same as the one that we have used for the other models. The only difference is the setup, that is, instead of binary classification, we have tertiary classification. In this case, if you look at the results with the baselines, then we see that for predicting the transition state, we do get much higher results for the random forest model. And that is also true for predicting the ICU and the non-ICU states. In general, we do get sufficiently good performance for precision. However, for recall, the performance is relatively low. But as compared to the baselines, we still get an order of magnitude improvement in terms of the results. A large number of features which were used in the model are in fact correlated, and thus to get a true gauge of the features which may be required or which may be contributing to the model, we did some additional analysis and reduced the number of features to just 20 features. And the results from the prediction are given in this table. So while we do see a reduction in performance, uh, at the same time we do see that the overall predictive performance or the predictive power is still sufficiently high so that even with this minimal model, we can make useful inferences. In order to understand what factors may be driving this model, we also computed the shape values for the model. The main takeaways were that there were few expected features like age in hours or let's say the length of stay are important features in prediction. There are a few other things that we observed. For example, PCO2, partial pressure of carbon dioxide, which is a measure of carbon dioxide within arterial or venous blood, is observed to be an important factor with the population bifurcated into two subsets, one with high importance and another with low importance. This was somewhat unexpected result. For vital signs, we see that heart rate, max respiratory rate, etc. are highly representative as top features. Medications from classes like narcotic analgesics, CNS stimulus, and anti-infectives were associated with future ICU care states. And high levels of albumin were negatively correlated or associated with the positive class. Lastly, we also computed the similarities between patient instances based on normalized feature Euclidean distance, and then we computed, or rather observed, patients for which the predictions were different, but they were sufficiently similar. And in those cases, all other factors being very similar, it was the differences, one or two factors, which resulted in different predictions. This analysis may shed some light on the key factors which may distinguish one patient from another and help in risk stratification. We hope to continue this line of analysis in the future iterations. To conclude, predicting the future states of patients in pediatric intensive care units, or PICUs, is a far-reaching problem for patient quality of life and even patient survival. Methods that are currently being used for gauging pediatric mortality risk and thus risk for stratification are mostly scoring-based systems, but with this paper, we hope to have demonstrated that these methods can be complemented via machine learning models. Our long-term goal is to create a risk scoring system that can be used in lieu of current risk scoring systems used in PICUs. Additionally, for future work, we propose to integrate the models described in this manuscript in a platform that may be integrated in the workflow of physicians and other healthcare personnel in this particular setting. Thank you.